it's informed consent. I mean, we have a duty to provide informed consent, no matter what our ideologic or political or other beliefs might be.
Hello and welcome back to another episode of Fierce Fridays. This is officially season 2, and after a much needed break, we are back. If you are new here, my name is Elise, and I am known by many as Samara's mom, and this channel was started to share her story and has blossomed into being able to talk to other people and share their stories and experiences as well. Today, we have Dr. Martin McCaffrey here to speak about his experience as a neonatologist. And I'm so grateful that you have agreed to take time out of your busy schedule to meet with me.
Oh, it's a pleasure to be here, Elise. Thank you for having me. And thanks for the great work that you do supporting families out there trying to navigate the waters, dealing with kids with a variety of different issues.
Yes, yes. It's been truly a journey, and I'm grateful for all the people like yourself that I have met along the way. Now, you and I haven't really spoken before. We've
Nope.
had very brief interactions online. So I like to know who I'm interviewing, and I looked you up, and I found some really interesting things about you. So I'm going to read this real quick because I thought it was quite impressive. So this says that you're a professor of pediatrics. Are you still at UNC Chapel?
Yes, ma'am.
Okay. In the Division of Neonatal Perinatal Medicine, you're also a retired captain in the U.S. Navy
Roger
and
that.
served as wow, and served as the director of neonatal care at the Naval Medical Center, San Diego, and the consultant to the U.S. Navy Surgeon General for neonatology. Wow. This says you're the director of the Perinatal Quality Collaborative of North Carolina. Are you still doing that?
Yes, ma'am.
Wow, you're very busy.
Ah, I got to stay out of trouble. This busyness gets me in more trouble. But anyway, that's another story.
I'm sure, I'm sure. And how I met you is through the trisomy community. And I see here that you're a member of the International Trisomy Alliance Board and the Be Not Afraid Board. So that is really amazing to see how involved you've gotten in the trisomy community. And as a doctor who's a neonatologist and has firsthand experience seeing babies that are born with different, diagnosis. So with your experience, can you talk to me about like more about your experience in terms of like how long have you been a doctor and what kind of things you're doing right now?
Yeah, so I graduated med school back in, wow, way back, 1986. And I left fellowship and was at that point a young neonatologist in 1995, in between a bunch of other things were going on, obviously. I was actually a general pediatrician for a while in the Navy as well, and was out on Guam serving there as a pediatrician, did that for 3 years. But so my experience has been to encounter a lot of children with trisomy disorders for sure. And the thing that I think sometimes gets left out is we talk a lot in the trisomy community, sure, about trisomy 18 and 13, but there's some other lesser known trisomies as well and other partial genetic disorders. But at this point, we're doing so much genetic testing that we're identifying things that really raise concerns for families and for parents, but we don't necessarily always know what they mean. I mean, we know even less about some of these things than we know about trisomy 13 and 18, which I would say we really don't know very much, actually. I've been taking care of trisomy kids as a neonatologist for decades now. I mean, since '95. So, I mean, we're talking heading on 30 years. But I think my greatest experience with them, in addition to my clinical practice, has been working with families like y'all on Facebook and working through the organizations that you mentioned. So, Be Not Afraid is one group that I've been working with for the last 12 years. They are a group that tries to partner with families who have prenatal diagnosis, and many of them are trisomy, especially 13 and 18 diagnoses, to help those families who are seeking to try and find support for their pregnancy and carry their babies to birth and beyond. We partner with them and we try to case manage them early on. And I've been really fortunate to work with some amazing people who are really expert at dealing with the challenges families face. I mean, the simple fact is the day that you get that diagnosis, that prenatal diagnosis, is the day you begin your trauma journey. And everything changes with that day. I think some people think, oh, the birth is really challenging and we need to be there for that. Sure, absolutely. But really, the trauma starts with the diagnosis. Everything that you thought was going to be, a great baby and a bright future that you were looking at is totally changed. And it may still be in very different ways a bright future, but it sure ain't the future that you were thinking of. And you need to find help and support along the way. So BNA has been great for that with me. I mean, I think through BNA, I'm probably working at this point on an annual basis, probably with about 20 to 25 families through BNA. I have 3 or 4 that I'm working with right now. The other thing that has really helped me appreciate what the trisomy journey is like is Facebook. I mean, I have a lot of bad things to say about Facebook, but I mean, the one good thing is I think it's been a great resource for families. And when they start seeing what is possible for kids with trisomy 13 and 18 from other families, they start to realize they may not know the whole truth about what might be and what hope there can be for a diagnosis with trisomy 13 and 18. So I spend a lot of time kind of, I don't know, some people might call it stalking, but I've been welcomed into all these Facebook groups. So trying to find people who maybe are looking for a little bit more support than they've been able to get. And not to knock Facebook groups, I think you can get a variety of different supports there, but trying to get some real solid medical information and direct people to real case management, I think is really critically important.
It's super essential, and that's how we met, was through Facebook. And there's resources that are out there like Be Not Afraid that I didn't know about when I was pregnant.
Right.
I actually went on YouTube, which is why I really love YouTube as a platform, because it led me to different organizations like Soft and it's the Facebook groups that exist. And so, like you mentioned, that initial trauma begins at diagnosis during, early pregnancy for many of the families, sometimes at delivery, but a lot of us find out during our pregnancy. And having that knowledge of other people really does make a big difference. So I am glad that you have joined all the groups because it makes, it's a change to have a perspective from a doctor, right?
Yeah.
We rely on ourselves a lot in terms of like from parent to parent, like just talking to ourselves and building friendships, but having a medical professional that can also give guidance has been super valuable. Um, so how often in your career how often have you encountered some of these diagnoses like the rare trisomies in your practice?
Yeah, I would say, at our place at UNC, we're a big referral center, and we've actually, I think, really done a great job actually over the last 10 years for sure, becoming a place that, I almost hate to use the term trisomy friendly, but that offers standard care to babies with trisomy that parents want to pursue that would be offered to kids with normal chromosomes. The one challenge for us, and it's a little bit, maybe we got off on this, but a little bit of a separate discussion is heart surgeries. But we have become a place that people will come to now, and people respect people's wishes about what they want done, with their pregnancy and with their baby, and are willing to support that. So I would say, between trisomy 13, 18, maybe in a year, we probably see in my NICU and even in our prenatal diagnosis, where neonatologists meet all the families for prenatal diagnosis and talk to them about what might be possible. Probably at least about 10 to 15 a year or so, at least, maybe 10 to 20. It's not a whole lot more than that, as you know, Elise. I mean, it's not those are not super common conditions. Unlike, Down syndrome is 1 in 1,000 babies. We're talking trisomy 18 is maybe 1 in 5,000 babies. And then trisomy 13 is 1 in 10,000 babies. And, what is going on now as well with prenatal screening and prenatal diagnosis, we're probably seeing a few less of those babies because what screening is doing, that is talked about by the American College of OBGYN, is being offered genetic screening, I'm talking about, through maternal blood samples. Very easy and convenient to do, not necessarily super accurate for trisomy 13 and 18, but every mom is now being offered this. There was a day, you know, about 10 years ago or so, where it was the moms with advanced maternal age. You know, if you were over 35, hate to say it, but that was like advanced maternal age, you were offered this kind of more intensive screening looking for genetic abnormalities. In a different form, whether it was from ultrasound or blood tests or other things. But now that we have non-invasive prenatal testing, we can actually get mom's blood, send it to the lab, and look for fetal DNA in that blood and try to make prenatal diagnoses. And then we look at ultrasound and other things. So now that that's being offered to every mother, I think there's going to be a higher likelihood, as we see in the Down syndrome community, that there's going to be more abortions associated with these babies because they're being picked up early. And also hand in hand with that goes medical abortions now that can be accomplished much sooner without surgical interventions. So, you know, the 1 in 5,000, 1 in 10,000, I'm not sure those numbers necessarily are going to hold over the years. I mean, we've certainly seen drop-offs in numbers of babies being born with Down syndrome, in spite of a maternal population that's aging. I mean, the average age for a mom having a baby now is definitely, you know, a good 4 years older even than it was 10 years ago. So you would expect more babies with these types of problems.
Right.
I'm not sure that's necessarily going to happen.
That's interesting. Like I didn't even think about the fact that, you know, these things are being off. I didn't know that they're being offered now to everyone because what even a few years
Yeah.
ago when I had Samara, it was because of my age, because I'm in that, what do they call it, geriatric pregnancy?
Yeah.
And so I'm like
Sorry,
that's
Lise.
insulting. But no, but I now to know that they're offering it to everyone is very interesting because it does provide people with opportunities to make decisions differently. Um, so that's interesting.
Well, the other thing to know is that, you know, what you want to know as a mom getting these tests is, if I get a positive test, what are the chances that it's a true positive? That's all you care about. We call that in the statistical world the positive predictive value. Um, what people will talk about with these tests, and I will hear maternal providers, you know, around the world talk about this. Oh, these tests, Marty, they're 98 and 99% sensitive and specific. Yes, they are, but that has nothing to do with a mom's test. So when we say sensitivity, I hate to go into stats too much, but when we say sensitivity, we're talking about a true positive. When we say specificity, we're talking about a true negative. So can the test pick out all the true positives in a bucket of 100 true positives? Can it pick out all the true negatives in a bucket of 100 true negatives? That's great, but that's not the real world, right? So in the real world, when you go out, there are a lot of people who don't have the disorder. And so there's going to be some false positives. The question is how many? And the fact is, the younger the moms are, the higher the risk for a false positive because less of them have the disorder. So the positive predictive value for a mom who's 20 versus a mom who's 40 for trisomy 13 and 18 is very different, very different. In fact, just based on that test alone, Elise, the positive predictive value, the chance that your positive test is a real positive for a 20-year-old mom for trisomy 13, it varies a little bit depending on which testing kit you're using, but it may be around 10 or 15%. For a 40-year-old mom, it may be up around 60 or 70%. So when you're saying the chance that you're positive that I am telling you about now is only 10 or 15% chance, you may as well go out and flip a coin a bunch of times to
Wow.
decide whether you've got a baby with trisomy 13 and 18. And this is a big problem with this testing. We don't do, well, let me talk about this testing. We don't do informed consent very well with this testing. Very often, and I see it on Facebook all the time, moms will get this test back, but they only got the test because they want to know the baby's gender, the sex. They
That's
didn't
why I
do it
went.
to find out all this other stuff. And
Hmm.
now they're finding out stuff that may or may not be real and having to deal with the trauma of that. As soon as you get that test back, bang, the trauma starts. And you start looking up trisomy 13 and 18. And if it's not real, we've put moms through a whole heck of a lot that they never should have had to deal with. And if it is real, they're just let loose out on the internet to see all the terrible things that are out on the internet. Because chances are she isn't finding your page right away. I mean, she's going to Wikipedia or Google, and Dr. Google is going to tell you all these horrible things. And now,
Hmm.
the trauma really gets rolling. So informed consent is not well done for this testing generally across the board.
Right, right. That's part of the reason why I want to have this conversation because I know there will be people that, including doctors that will watch this and hopefully it will start changing how information is presented. Um, and that's one of the things I'd like to get into. So healthcare has changed a lot over the last few years, right? And so even like me having a baby 15 years ago versus having Samara 4 years ago, the experience was very different. The information was very different. The things available are very different. How have you seen the care for children with trisomy advance or not? I don't know, in your career.
Yeah, well, I'll take a few steps back just for me personally, if that's
Yeah,
okay.
of course.
So, before, if you would have talked to me and had this interview in 2008, I would have said, boy, those babies with trisomy 13 and 18, I'm so sorry you're dealing with that. But, they don't live, they don't survive, Elise. And, if you're going to continue the pregnancy, that's what I would have supported at the time, will help you with your baby as, they comfortably expire over the following days or weeks or months. Um, in 2009, I went up and did a press conference with my daughter, Shay. Shay has Down syndrome. She's 23 now. So we went up to do this press conference in DC, and it was Kathy McMorris Rogers, who's a legislator up in Washington State, has a child with Down syndrome, and Trent Franks, who's no longer in the Congress, but he was from Arizona, talking about the impact of the Affordable Care Act on kids with special needs. And indeed, my prediction was that it was going to be some severe impacts and they were not going to be good impacts. But that's what I went up there with Shay to really talk about. What I found when I got there was an absolute epiphany. I was surrounded by about 10 or 12 families, and you can see the pictures I've got up in some places. I'll send one to you if you'd like. But
That'd be great.
of these families with people with trisomy 13 and 18. And I looked around and I'm like, are you sure your kids really have trisomy 13 and 18? I mean, because none of them survive beyond a year. And I'm looking at your daughter here, and she's clearly got some handicaps and physical issues, is in a wheelchair. I mean, has severe, it clearly has delays, but she's like about 18 years old. I mean, how can this be? They're like, Marty, you haven't been told the truth. Um, you have to look into the literature. The textbooks are not correct, and they're not based on good literature. And there's clearly literature out there that will tell you, and there was. I went back home and looked up this literature that babies and children with trisomy 13, 18, 40 to 50% can survive at a year. And I'd never seen this literature. And I'm looking through the textbooks. I'm like, this is just unbelievable to me. It opened my eyes. It introduced me to an incredible woman who maybe Barb Farlow, whose daughter Annie has had trisomy 13 and died at about 3 months of age. And there were a lot of concerning circumstances around that death. But Barb and I became fast friends, and we started working with families that she was being contacted by who needed support for a variety of things, not just trisomy 13 and 18. But it really launched me on the road. It opened my eyes. It was my road to Damascus moment for sure with this community, that we were not really necessarily following the science. And what has changed over the years in advocating for these families through the work of a number of people, I mean, and you know many of them, Elise, but people at SOF, people like John Kerry, I mean, John, who was willing to publish in the American Journal of Medical Genetics articles that talked about how we necessarily were not thinking properly about these babies, work done by people in Japan who were very interested in supporting these babies and demonstrating they could have long lives. What has changed over the years up until the current day, even over the last 4 years, is multiple publications now that have shown us that babies, children, people with trisomy 13 and 18 can live much longer lives. That we no longer can call these lethal anomalies. We just can't. It's not accurate. And what is accurate, however, and I've written about this, is that as physicians, if we decide we will call something lethal, we can make it lethal. I have unbelievable power as a physician. If
Mm-hmm.
I tell you as a young mom coming in that your baby has a lethal disorder and you sort of half trust me, what are you going to do? You're probably going to believe me. And you may stay with me and do further testing after your NIPT, your blood test, which is a screening test, by the way. And if you're going to get a real diagnosis, should be followed up with an amnio or chorionic villus sampling, some other specimen to truly diagnose. I don't necessarily recommend doing that either, but you're going to believe me, and maybe you continue down the road, or you might sadly go out to an abortion clinic and say, I just can't handle a baby like this. So we have the power to make things lethal. The other thing is that if you're convicted and you're absolutely going to have your baby, I would say, all right, I'm with you. Let's do that. But you know, your baby has a lethal disorder. And if I keep telling you that, and I keep telling you that the best thing for your baby is after birth is a hospice route, and warmth for your baby, and psychosocial support for your family, and warmth for your baby, and narcotics for your baby, that's probably the route you're going to go down. So as physicians, we have incredible power. And to that power, there was a great publication by Annie Janvier, who's a neonatologist up in Canada. Barb Farlow was on this publication as well, along with Keith Barrington. Annie and Keith are husband and wife neonatology team. But they reported on what happens when babies are prenatally diagnosed with trisomy 13 or 18 or postnatally diagnosed. And what does quote unquote palliative care look like for those babies? The one factor most highly associated with a baby never leaving the hospital with trisomy 13 and 18 is a prenatal diagnosis. And why? The conclusion of Annie and Keith and Barb was that with prenatal diagnosis, the intent of palliative care, I'm paraphrasing a little bit, is to expedite the death of the baby after birth. So there's no plan for feeding even in many of these babies. So it's narcotics, which may suppress respirations and warmth and psychosocial support for the family. And so what happens is many of these babies never leave the hospital.
Right.
So that's the power we have. But indeed, what has changed is more people are electing to try and find medical support for their babies. And we are publishing on that. I mean, the data is coming out. And it is showing that these babies, it was a great recent publication from Cincinnati over the last year, which has really become a great place and supportive place for babies with trisomy conditions, as well as a number of other big centers, but not enough of them. But what they show is that with medical interventions, if this is what families want, and oftentimes they can be complex medical interventions, babies can survive out to a year at 50 to 70%. The other issue that comes up then in all of this is we know that the babies with trisomy 13 and 18 have some unique problems. One thing we cannot change is their cognitive and motor impairment. If they're full trisomy 13 and 18, they're going to be severely delayed mentally and in what they can do motor wise. And there's a spectrum there. Some develop a little bit more than others, to be sure. but it's not going to be obviously anywhere close to normal development. So that we can't change. We also have realized over the last, I would say 5 years, you're asking about a 4-year window, I'd say 5, 10 years, that one of the myths about babies with trisomies was that when they come out and they're born and over the first days or even weeks, if they don't breathe well or they stop breathing, they have what we call apnea, which is cessation of breathing. It's because their brains are so abnormal, they just can't survive. We would call this central apnea, meaning central, it's mediated by the brain, and they can't breathe because of their brain for some reason. In the past, the way I was always raised, and I said this, you know, I said this to multiple families. Your baby isn't able to breathe, your baby's having apnea. I think it might be time to let your baby go. And what we have realized now is okay, there might be a subset of babies with central apnea, but guess what? There are things that cause central apnea that are potentially treatable. One of them is seizures. And we have not spent a lot of time thinking about seizures early on in these babies. So that not breathing might be central, but you should be thinking about seizures then. The flip side, though, that we have realized is that many, probably most of these babies, if they are having what doctors are calling apnea, is probably obstructive apnea. And obstructive apnea is a very different beast. What it means is there's some blockage or collapse in your airway where it makes it hard for you to breathe. And we have lots of ways to deal with that. Sometimes that might get better as babies get bigger and their airways get stronger. In babies with trisomy, that may not be the case. And, the person I turn to the most on a regular basis when I have airway issues is up in Michigan, another great place now for trisomy babies. And it's Dr. Glenn Green, huge friend of the trisomy community. And Glenn and I have been working together on airway related issues probably for close to 10 years now, trying to manage babies. And he's been an unbelievable support. But this is a guy who's probably dealt with the most trisomy babies in the world with airway issues because people know that he understands the problem. And what he and I have talked about, and I agree, is that oftentimes these airway issues do not get better like they do in a baby with normal chromosomes. I can have babies deliver who might have noisy breathing, maybe have obstruction. And what we call that sometimes is malacia, meaning softness of the airways. The airways collapse. And it can be in the upper airway, it can be in the middle airway, it can be in the lower airway down in the lung. Oftentimes that will get better with babies with normal chromosomes. Oftentimes not the case for babies with trisomy 13 and 18. So they need more intervention if they're going to survive. And that intervention may be just extra pressure in their airway. So it could be CPAP, it could be high flow nasal cannula. Many of them, though, have pretty severe malacia. And what they may require is actually a tracheostomy that will allow them to get home and offer them the pressure that they need to support their airways to stay open. And so I think that is one of the new things that there's several recent publications this year, even from a variety of places, talking about obstructive airway disease in babies with trisomy 13 and 18. And I think for parents out there who are dealing with babies who are having apnea, and they might be being told by docs who don't know the literature or are just stuck on these babies are lethal and can't get out of the central apnea mode. They should be informed that obstructive apnea is something that we can deal with. And the way to diagnose that and get at it is with number one, a sleep study, number two, an airway evaluation. So that is another big area. So we talk about central apnea, obstructive apnea. The last thing I would say about what's different is heart surgery. 80 to 90% of babies with trisomy 13 or 18 are going to have congenital heart disease. Some are more serious than others. Some are more complex than others. But what we've realized over the last number of years is that these babies just don't die because you take them to the operating room. And that is what we have said for years. Oh my gosh, I'm so sorry. Yeah, your baby with trisomy 18 or 13 survived to be 2 to 3 months old. But that big VSD they've got, there's just nothing we could do for that because if we take them to the operating room, they're not going to survive. The literature is clear that babies with trisomy disorders can go to the operating room and survive. I mean, it's just undeniable. So to give you an example, a great publication, well, let me say before I say that, we don't have a lot of babies with trisomy 13 and 18 who've gone to the operating room. But the data that we do have in places that have done this and been willing to try this shows us from about a year and a half, 2 years ago, surgical, the STS database, so Society for Thoracic Surgery database, great publication, talking about survival for babies with tri-13 and trisomy 18 after surgeries. Different types of defects, but if you're talking about one of the most common that we see, ventricular septal defect, VSD, which oftentimes is big in trisomy babies, oftentimes will not close on its own like it does in babies with normal chromosomes. Interesting, right? The airways are different, the heart's a little different. And we don't know why. But if you had a baby who was 4 months old and congestive heart failure or developing worrisome signs and needed a heart surgery for a VSD, you take that baby to surgery, no pun intended, in a heartbeat. I mean, there just wouldn't be a question. This is one of the most common congenital heart surgeries that we do.
Right.
But with a trisomy baby, everyone hems and haws, and then these babies get into enough trouble that they're not even candidates for surgery anymore. So
Right.
the numbers are, if you will take them to surgery, for a baby with normal chromosomes, the survival rate, 28-day survival rate after the surgery is, well, the mortality rate is 0.5%. 0.5. So
Wow.
99.5 out of 100 babies with normal chromosomes will survive after that VSD surgery. Okay, what about the baby with trisomy 13 or 18? The mortality rate is 8%. Okay, so that's over 10 times higher, right? So if your doctor says, well, the mortality rate for babies going to surgery with a trisomy and a VSD is 10 times higher, you're thinking, oh my gosh, my baby will die. But when you see the numbers, what you realize is that 92 of 100 babies survive a VSD surgery with trisomy 13 and 18. Yeah, the mortality rate's 10 times higher, but we're so good with the other babies. Yes, more babies with trisomy will not survive, but it's not a death sentence. So there have
Right.
been more people willing to take these kids to surgery. And so when you're willing to do those surgeries, more of the babies are going to survive. So the numbers that we have of, 50 to 70% at some of the centers that are really on the tip of the spear pushing this, could be even higher. I don't know. If we would be willing to consider the heart surgeries.
And it's interesting because when you talk about the power that doctors have, right, and how information is presented to help people make decisions, it's a huge factor in what many of us have experienced. And it goes into my next question, which was addressing biases, right? Because we all have our different biases. Everyone comes
Yep.
with something that they strongly believe. And what I experienced, and I know that many of the moms that and dads that I know, is that some of the doctors, not all, because we had excellent doctors, but some of the doctors, um, their biases showed in their practice. And so it was very clear to me which doctors were willing to not necessarily that they were on board with doing things for trisomy, but they were willing to respect our decisions
Yes.
and
Yes.
were open to listening to us. They got to know us. They did not impose their opinions, and not just their professional but their personal opinions on us, because and this is the other thing, and I meant to say this at the beginning, and some people know that I have worked as a medical social worker for many, many years. So I've worked alongside doctors in cancer centers and pediatric clinics and hospitals, um, and it's important to provide information because that's how people make decisions. Um, but sometimes I've seen, both in my professional career and in my personal career, I've seen doctors present the options that they like or that they feel comfortable with, and will present the other will neglect to present all of the options, or will present them with this in a way that is almost disdainful, like you really don't want to do that because, but it's more so on their personal biases. So what would you suggest about that? Because I actually said to one particular doctor, your personal opinion shouldn't affect your practice where I can tell how you feel about my child.
Oh man, you just nailed a whole bunch of things. So it goes to the core of what being a physician is, what you described. So our job has to be, and I mentioned it earlier when talking about prenatal diagnostic testing, the genetic testing. Um, so with regards to the trisomy community, there has been just a devastating lack of informed consent. I mean, we're seeing it on the prenatal diagnostic side, to be sure. But then once a diagnosis is made, I agree with you. There are more and more people that are willing to provide informed consent. And even though they may not agree with your choices, they're willing to support you. I would argue, though, that no one needs to know what your personal choices would be as the doctor. I mean, just keep that to yourself. I mean, there are, three options on the table, like with a prenatal, well, I'll talk about that. I mean, whether you're going to think about abortion or you just want to have hospice care or you want to have stabilization and evaluation of your baby, put the options on the table. And they're all, at this point in our society, those are all the reasonable options and live with what the patient and the parent want. But you need to inform them about each of those options.
Mhm.
Um, so once a diagnosis is made, I think we have not done a very good job at all about talking about options, even related to comfort care. I mean, some people, we get into definitions here a little bit. I mean, I think there's a big push, even in the Facebook communities, talking to moms who've got a prenatal diagnosis, this push to at least get to a live birth and then comfort care. And some people would even call that comfort care, which I would call hospice care, because at that point you're making a decision that the baby truly does have a lethal disorder. I mean, you want them to get to a live birth, but you're not going to provide any medical interventions. You're only going to provide comfort. Hospice and comfort are the same thing. Palliative care is a different animal. I mean, when we use the term palliative care, at least in my institution, we are talking about an infant or a child or an adult with a chronic disease that may be life-threatening, but that we are going to undertake medical interventions to improve quality of life, to actually extend life. And at some point you might decide that the disease becomes severe enough that you're going to move into a hospice situation. Um, every cancer patient is not a hospice patient. I mean, a lot of them are palliative care patients, right? So,
Correct.
and they should, and you hope that they're going to have extended lives, but they're going to have to live with their cancer. Um, and so I think the verbiage is really important. But I think what we, as maternal providers, whether it's an obstetrician, a maternal fetal medicine specialist, or the pediatrician or neonatologist counseling families pre-birth who have decided they want to continue a pregnancy, do a terrible job about generally right now is saying, okay, the other option beyond hospice and comfort care is every trisomy baby is different. I mean, if you've seen one trisomy 13 or 18 baby, you've seen one. You cannot put them all in a big bucket that is lethal. Um, and at best, their conditions are life limiting. And honestly, Elise, I kind of am coming to hate the term life limiting because I'm life limited. You're life limited. We're
We
all
all
life
have an
limited,
expiration date. Oh,
right?
well, the term incompatible with life is the one that caused my skin because that's what I was told.
Right, right.
You know, and I'm like, well, what does that mean? Am I having an
Fatal
alien?
fetal anomalies, incompatible with life, or lethal. That those are the terms that get thrown out
Mhm.
there. And actually, people try to build in legislation now where say, okay, you can have abortions up for incompatible with life disorders up until a certain
Yeah.
age. I mean, we need to get rid of that kind of terminology. I think is really problematic because if you're advising a mom and you're offering abortion, for instance, take a step back to that diagnostic period, and you're using terms like incompatible with life, that I mean, that tells the mom my baby has no hope at all. And it really biases her thought. Whereas if you're at least say life limiting, then a mom might go home and say, life limiting, maybe they might have a life, you know, and it might make them
Yes.
think a little bit differently. But I think once a mom makes a decision that she wants to continue her pregnancy, I think we're pushing a lot of moms off into that perinatal hospice world. And we are not doing a very good job for a lot of reasons, I think, about talking to them about the valuable life their baby might have. Now, yes, it might be a baby who's severely impaired. Yes, it would be a baby with medical complexities. I mean, you know that well from Samara.
Of course.
But that is your decision. It's not my
Right.
decision.
Right.
So what we see in the literature is really fascinating. I wish maybe I need to figure out how to do this, but it's a little bit, these are two older publications now, 2016, 2017, old, but not that old, where three questions were asked in two different studies of obstetricians and maternal fetal medicine docs and neonatologists. First question. The OB one was conducted in the UK, Australia, New Zealand. The US one, the neonatology one, was US neonatologists. Three questions, all with the same questions, which was really pretty great. First question, is trisomy 18 a lethal disorder? Obstetricians, 90% yes. Neonatologists, 88% yes. Okay, we're all on board. This is pretty darn lethal. Second question, is trisomy 18 incompatible with life? Obstetricians, 70%. Neonatologists, 60%. All right, now wait a minute. You're telling me it's lethal, but now a bunch of you are saying, like 20 or 30 more percent are saying it's compatible with life. That really is, that doesn't make sense to me. Okay, last
Mhm.
question. Is trisomy 18 compatible with a meaningful life?
That's the question that people
Obstetricians,
ask.
obstetricians, 10%.
Mhm.
Neonatologists, 12%.
Mhm.
So it is not about, even back then, whether we could help these babies survive.
It's quality
The,
of
the
life.
it's the care is not futile, it's people judging the life as futile.
Exactly. And that's where that implicit bias comes in of, well, is this child's life worth it?
Yep.
And the saddest part is that many of us who have had children with these disorders have literally had those questions asked of us, like, well, what's the end point? Is it worth it to do X, Y, and Z? Do you really want to proceed with X, Y, and Z? And it's very hurtful because it's like, well, I love this child, and for me, I am determining that her quality of life is okay because I'm like, we are, she's loved.
Yeah.
And so that's where the bias comes in because, and what I've seen is that bias impacts some of the people's, not every doctor, again, like I mentioned earlier, it does tend to impact practice. Now, you mentioned earlier that you have a daughter with Down syndrome who's now 23 years old. And I'm curious, now you're a doctor, you've been a doctor for a long time. Was your Down syndrome is obviously more well known, a little bit more familiar to people. What was your experience like in terms of now as a doctor having a child with this diagnosis? Were you treated differently than what you've seen many other families treated? Like how did that go for you?
Yeah, I think Down syndrome is hard because what happened, what has happened over, I would say, the last 50 years with Down syndrome, and I wrote an article on this that John Carey published. It was called "Selecting the Road Previously Not Taken," and reflecting on the Down syndrome experience in the context of the trisomy 13 and 18 experience, and hoping, praying that we would learn something from what we did with Down syndrome over the last 50, 60 years. We've gotten to a point now where Down syndrome is accepted. I mean, Down syndrome is not looked at as lethal or incompatible with life. It is not looked at as life limiting. Um, Nobody suggests at this point that we shouldn't do cardiac or heart interventions for a baby with Down syndrome. I mean, that question never comes up. It came up well into the 80s.
Wow.
In the literature, it came up well into the 80s. We were denying people, kids, with Down syndrome who were great candidates for ventricular septal defect and AV canal repair surgery based on their diagnosis. So it isn't like this is 1960s and 50s stuff. You know, when we called Down syndrome people mongoloids and put them in institutions and told parents, don't even think about taking your baby home. So, you know, you fast forward to now, and what I would say is yes, Down syndrome is totally accepted. I mean, there's opportunities that are available. You don't have to fight for medical care. But it was interesting when Shay was born in my own hospital where I was the NICU medical director. Teresa and I were asked multiple times whether we wanted prenatal testing based on some soft signs that we saw on ultrasounds. And we repeatedly had to say no. But the pressure was on there. I mean, and we knew some of these people, and they knew us that this didn't matter to us. I mean, the only thing that mattered to us was let's just do some ultrasounds. If there is something that's related to Down syndrome based on these soft signs, if our baby has a heart defect, that would be good to know about because we can be prepared for that. So I think in that sense, we didn't deal with any of the trauma and challenges that you all, families with trisomy 13 and 18 kids, have dealt with. I suspect if Shay was born back in the 60s or 70s, or even the 80s, we might have. And we've been very fortunate with Shay. She doesn't have a lot of the medical issues. She has some severe developmental issues related to autism and severe developmental delays. So, you know, the funny thing is, Down syndrome, I mean, the push now, especially, you know, when you're talking about people, especially in the pro-life movement, trying to make a way for Down syndrome babies and, you know, push out that, you know, we shouldn't be aborting these babies per se. It's a little, in some ways, I'll say a little offensive to me because what we're trying to make the case is that we should have Down syndrome people because look at all the things they can do.
Mm.
And my daughter actually with Down syndrome can't do any of those things. You know, she just can't. But she is no less valuable to me than the Down syndrome person who graduates college or that is in the Special Olympics or is on
Mm-hmm.
television. I mean, you know, all of that is great. I mean, I'm glad those opportunities were there for those kids, but my daughter
Exactly.
is incapable of that. And so, in some ways, I do feel a little bit of, we don't feel pressure anymore, obviously, because Shay's here and she gets all the medical care she needs, and which isn't
Mm-hmm.
much. But I understand where you guys are coming from. It's people judging the value of your child's life because they can't offer certain things. I mean, if we had trisomy 18 kids who were going to college, they'd be all over the place.
For
But you know,
sure.
the dark truth, though, is that many people still don't want kids with Down syndrome. So now that we have prenatal diagnosis and we have early medical abortions, the best data we have from California when you could do early diagnosis and medical abortion is that 90% of Down syndrome pregnancies are aborted. So
Wow.
we're not denying the care after birth, but we're denying a whole lot of life before birth. Um,
Yes.
so, I mean, what has happened with the Down syndrome community is the discrimination has shifted. I mean, it's all become prenatal discrimination, and no one is necessarily going to turn their nose up at us because we have a child with Down syndrome. Although I will say, one terrible story after Shay was born, Teresa and I were at the Naval Medical Center walking through our courtyard there with Shay for a medical appointment, her a follow-up appointment, well baby check basically. And we met a someone who we knew, but not super well. And they saw us with Shay and they congratulated us and looked at Shay. And then they said, oh, you know, I realized that they realized she had something else going on. And I said, yeah, we found out Shay has Down syndrome. And this woman looked at me and Teresa and said, well, didn't you guys have the test?
Hmm.
And I'm like, do you want me to put a pillow over her head right now? I mean, Well, I mean, what the heck? I mean,
Right.
you know, so yeah, there's still that bias still lurks out there. I think people are willing to tolerate, Down syndrome because of all the publicity that's out there. But for many people, yeah, that's for you, but not for me.
Correct. Exactly. Exactly. And so, with all of that being said, I have two last questions. And I guess the first one would be, um, did your practice and how you handled patients change because of your personal experience? And then
Oh
to
yeah.
end it, yes, okay, go ahead.
Yeah, oh, absolutely. Well, I mean, Shay totally changed me. I mean, it made me so cognizant of the bias and the discrimination that's out there. I mean, I always thought we should have people with Down syndrome in the world. I mean, even in college, I worked with a camp as a counselor for kids with special needs and a bunch of Down syndrome. I mean, I've always, that's never been an issue for me personally, so always fully supportive of that, but I never was aware, even as I was growing up, sort of around it, of the bias that was there in terms of kids not getting surgery, even into the 80s. I mean, I was in med school 82 to 86. So early 80s, we were still denying some of these kids heart surgeries. It just wasn't apparent to me. So, I mean, the other thing that really changed, I never would have gone, Elise, to that press conference if I didn't have Shay.
Right,
That press conference changed and rocked my world. I mean,
right.
for good or for bad, it threw me into your world.
Yeah. It
And
opened your
I
eyes
wouldn't
to
be,
things you didn't know about.
I would not be here talking to you today if it wasn't for Shay. And I wouldn't have worked with, what I think has been the greatest privilege, had the greatest privilege to work with the hundreds, probably thousands, maybe thousands of families at this point that I've
Yeah,
worked with over the years. It's all because of Shay. I mean,
yeah,
my eyes never would have been opened. And I think I might still be on the train of what are we thinking? Okay, we'll call it life limiting, but the best we're going to do is hospice care. You want to stabilize and evaluate your baby and really see what's going on. I will say one last thing. I'll just throw this in. I mean, I think it's important because I've seen more and more and more of this in dealing with families over the last 2 or 3 years. Is babies who have a prenatal diagnosis of trisomy 13 and 18 being told after they get the prenatal diagnosis and they're getting subsequent ultrasounds that their baby has hypoplastic left heart. Um, we did with Soft last month during Trisomy Month. Several of us, including CT surgeons and cardiologists, were on that virtual event on March 18th, talking to families about a number of issues. And what is absolutely clear is no one should be making a diagnosis saying someone has lethal hypoplastic left heart based on a prenatal ultrasound. You might say there's a suggestion. I'm worried. It could be. Um, but I am worried that once that prenatal diagnosis is made, more and more people now are looking very, very closely at the left ventricle based on their own biases, I think. I don't have data to support that, but I think that's true. And calling hypoplastic left heart, which when you hear hypoplastic left heart as a neonatologist or cardiologist, you think, oh my gosh, I mean, you're looking at best at a 70% survival over time with 3 major surgeries. Plus, you're throwing on top of this trisomy 18 or trisomy 13. What do you want to do with this? And so I think we need to be very, very careful about that as doctors in calling that and using that to advise folks. What I tend to advise folks to do with their prenatal care and at delivery is think about stabilizing and evaluating your baby. Have people do what they would do for any other baby with normal chromosomes in the delivery room, stabilize your baby, bring the baby to the NICU, and get the information you need to make the best decisions you can make. Because quite honestly, I'm not living with that. I don't have to deal with it 6 months in the middle of the night when you wake up and you don't have your baby and you have a whole lot of what ifs that you're dealing with. I think people should think more and more about that, and we as physicians need to be discussing this as an equal option.
Okay. And thank you so much for that because you answered my last question without me asking it. It is what would be your takeaway for medical professionals? And it's to really just be one, there's a lot of research out there that's happening that I think people are not, in tune with and haven't seen. So these diagnoses, if you're seeing 10 to 15 a year, that's extremely rare, which means most doctors in their career may see one or two or a
Correct.
handful, right? Or
Right.
a handful a year at that. And so, finding out what resources are available, referring to other professionals that do have more experience, seeing what's out there. Any key takeaway for parents?
Yeah, I would say with this diagnosis, I mean, I think the ideal world for parents, especially now that we have more and more prenatal diagnosis, and I'm kind of focusing on that. If you're prenatally diagnosed, I think getting in touch with an organization that understands the trauma that you're dealing with, that can deliver trauma managed case management is really, really critical on a very personal level. Um, Be Not Afraid has been a great place to do that. What we realized at Be Not Afraid, however, is that the need is so great, Elise, that we as a single organization cannot do it. Um,
Right.
so what we've done with Be Not Afraid is come up with training modules. We have a formal training program for organizations that are committed to this kind of work, that have at least a dedicated person in their organization for this, to undergo the training, which it takes a while. There's reading involved. There's a number of modules involved, and then get designated as an org that can do a good managed care model for these families. The place that a parent can go right now to find these orgs, and we've trained now in 11 states. So they're not all Be Not Afraid. They're different organization names. But if you go to prenataldiagnosis.org, that will give you a contact on the front page. And that person that you contact will get you out to a trained organization in your region. Our hope is to train orgs in every state, so that there's access and even face-to-face access. I mean, the original Be Not Afraid model was we would go to the deliveries. We would try to be there. So it was a regional project initially in the South and mainly in North Carolina, South Carolina, and Georgia. Um, but the perfect world would be case management, orgs in every state, people who know trauma-informed care, that are hooked with medical providers that can give you good, solid, informed consent information to make good decisions, and that will follow you not just through the pregnancy, but afterwards. Whether that means that you did elect to go ahead and do hospice care for your baby, or you elected to get medical intervention for your baby. Because as you know, if you get medical intervention, you need help for the next year, 2 years, 3 years. I mean, depending how complex the babies are, you really need someone you can fall back on that will give you the big picture. So I think that's a perfect world. We're not there yet, but I think we've got to start.
Yeah, that was so well said. Thank you so much for everything that you've said in this interview. It's been very enlightening, and I really hope that someone or many people are transformed by these stories, that they are become more open to hearing it. And it's not about making people, like I always said, it's not about having someone make the same decision I made. It's about having someone make an informed decision, which you
Yeah,
so clearly said in this interview over and over. I really appreciate you highlighting that point, informed decisions. And that's in life, right? If there's one takeaway,
yeah, right.
informed decisions in anything are super important. So thank you so much for your time and for sharing your personal experience with us and your professional experience. If you have not subscribed to this channel, please subscribe. There will be additional videos from other families, not just from the medical community, but we've been highlighting stories from all walks of life of people who have overcome challenges and are doing well despite the circumstances that they have experienced.
Hey, can I jump in on one thing that you've had up
Sure.
that I have absolutely loved? I
Yes.
loved watching the interview you did, the presentation. Actually, it wasn't you. Nathan and Savvy
Yes.
talking. So young teens, young siblings talking about the
Yes.
impact of their sibling
Mm.
with a trisomy condition on them and how it's influenced them. because very often I think parents worry about what will be the impact on my other children. And
Mhm.
my experience and the published literature experience and Nathan and Savvy's experience is, yeah, it's challenging, but it changed me in ways that were so good and important for me that never would have
Awesome.
happened if I didn't have that sibling.
Yeah. Yeah, thank you for bringing that up. Yes, because it's nice hearing other people's perspectives. Because one of the things that families are told is your children will suffer, your relationship's going to suffer. And yeah, there are
Yeah,
challenges for sure that come
yeah.
with having a child with special needs. But there's also beauty in it, and there's ways to overcome it. And perspective is everything. So thank you so much for highlighting that and for taking the time to speak with me. I hope that you share this video with people and that, let us all be a light in this world. Thank you so much.
Thank you, Elise, so much.